Welcome to episode 5 of the second season of CLOT Conversations from Thrombosis Canada. I'm David Airdrie, Executive Director. Today, Dr. Maha Othman from Queen's University in Kingston will be leading the interview as our co-host, Dr. Jamil Abdurrahman, is unavailable.
It's great to be back, David, although I definitely missed Jamil today.
We both do. We're here to provide you with updates on diagnosis and management of thrombosis, featuring interviews with authors of recent research publications and highlights of education programs from Thrombosis Canada. Thank you for joining us for this episode.
Well, in this episode, we will be discussing a paper from the Journal of Thrombosis and Hemostasis entitled 2023 ISTH Update of the 2022 ISTH Guidelines for Antithrombotic Treatment in COVID-19. And we are very pleased to have two of the co-authors with us today, Dr. Sam Schulman from Hamilton and Dr. Michelle Sholzberg from Toronto.
Dr. Sam Schulman graduated from Karolinska Institute, Stockholm, Sweden in 1977 and has worked with coagulation disorders since 1984. Research activities have been clinical studies in venous thromboembolism, in hemophilia, and bleeding. Dr. Schulman is Associate Professor in Internal Medicine at Karolinska Institute and since September 2004 also Professor in Medicine at McMaster University. He is Director of the Thrombosis Service at Hamilton General Hospital. And Dr. Sholzberg is a hemostasis-focused hematologist and clinician scientist with a focus on coagulation, the division head of hematology oncology, and the medical director of the coagulation laboratory at St. Michael's Hospital. She's also the director of the Hematology Oncology Clinical Research Group and co-director of the Hematology Immunology Translational Research Theme. Good morning to both of you, and thank you for joining us today. It's great to have you here.
Good morning.
Yes. Morning. Thanks for having us.
Okay. Thanks, David, and happy to have you, Sam and Michelle. Well, as we all know, according to the WHO, as of May 5th of last year, COVID-19 is no longer considered a global emergency. However, I think we all continue to see cases, sometimes prevalent across some areas of the globe. And there were some cases, some spikes in cases last year for sure. And we are here today to highlight some key recommendations about the types, the regimen of anticoagulation in various patient types, the non-hospitalized, the hospitalized, critically ill, and non-critically ill, and maybe even have after hospital discharge, and maybe shed some lights on COVID vaccination and VITT. So why don't I start by asking, why was there a need to modify the original guidelines for antithrombotic treatment in COVID-19 that was published in July of 2022?
So we felt that with a large number of new randomized clinical trials being published after the 2022 guidelines, there were about 16 randomized trials, new randomized trials, and they brought new evidence to us, and we felt that we had to deal with it because it would change some of our recommendations. And also because even though the pandemic was declared over, the disease is not gone. It appears here and there in our country. We still see some patients in the intensive care unit quite sick, but more importantly, since ISTH is an international organization, we tend to all countries and we want to improve health everywhere in the world. And in several countries with less advanced healthcare, there hasn't been widespread vaccination and patients are getting sick still. And it's important to inform them also on the most up-to-date data. And fortunately, what we recommend are drugs that are not very expensive. Actually, they are available in almost every country in the world. So it's not that our recommendations are out of reach for these countries.
For sure. So why don't you talk to us a little bit about how you gathered the available evidence? I think people are always interested to know the search strategy, the selected studies, and especially about the new section on vaccination and VITT. Maybe even a bit of idea about the class of recommendation and level of evidence.
So we used the old panel that with all the members, and Michelle was a star member because she was on top of everything, and because of that we moved her over from the previous section. I believe you were in the outpatient section, and moved her over to the vaccine and VITS section. And we needed to add an expert, a content expert there. And Donald Arnold from McMaster University was almost a given one because he's one of the world authorities on this and has led important studies. He also asked, after some work on this, to add his PhD, Ishak Nazi, who is more knowledgeable regarding the technical parts of testing and the biochemistry. So we had two new members. And first of all, we extended the literature search. So we had literature search from the initial guidelines, and then we could use the same framework to add just the new dates for until present, so to speak, of all those questions. And then we had to create templates for VIT and vaccine. And that became a bit of a difficulties because it doesn't fit into the other templates. The other templates were all about antithrombotic treatment, but here VIT is different, and we had to rethink, and we had very good help from the same methodologist, Helene Resnick, as we had in the initial guideline, and she's very structured in her thinking and helped us to get it right.
Well, thank you. So my next question is really starting to talk about the anticoagulation for the various patients. So why don't we start by the non-hospitalized patients? And I want to ask, has the recommendation for anticoagulation changed from the previous guidelines? And was there a new level of evidence to that?
So I don't know if Michelle wants to jump in also, because you were involved in the previous guideline section on this. But first of all, there was no data on low molecular weight heparin, and there were two new randomized studies that were published in the meantime, and both showed no effect. So overall, we have no effect of antiplatelet agents, we have no effect of low molecular weight heparin, we have no effect of DOACs. And with DOACs, we could modify the recommendation because there were additional studies adding to our understanding that there is no effect of giving DOAC prophylactically. So the level of recommendations increased to the quality of the evidence increased to the highest level of A, because there were so many studies there. I mean, 4 studies that were all going in the same direction, no effect. So the only thing that is still there as a weak recommendation is, interestingly, sulodexide, that we don't have in Canada, but actually in some countries with less advanced healthcare. And it was done in Mexico. And that one showed the effect of preventing hospitalization. It's only one study. There's not been another study to what we could find, but it's still there as a possibility. It's a cheap drug. And so if it's available, that's the only one that maybe can be used for outpatients that have not been hospitalized yet, so to prevent hospitalization.
Thank you for this. And I want to clarify to people that when we say non-hospitalized, we mean those who have COVID-19 diagnosis, but remained in the community without a recent hospitalization. And I know we'll come to some definitions later on in our podcast. So why don't we now move to the non-critically ill patients? So those are hospitalized with no critical illness. And was there a change in the recommendation of the heparin use from the previous guidelines?
Well, one important change was that in non-critically ill patients hospitalized. So they're hospitalized for COVID-19. They're not hospitalized and then get COVID or happen to be positive for COVID. They're hospitalized because they're ill in COVID, okay? That's important. All our recommendations are regarding those patients. So low molecular weight heparin or unfractionated heparin at treatment dose was forwarded in our previous recommendation as beneficial to patients at higher risk and better than low dose, better than prophylactic dose. But we had initially said that it was mainly to reduce risk of thromboembolism and end organ failure. But now we had about 8 studies all going in the same direction and showing either a trend or significance to reduction of death. And that was also in 2 meta-analyses, one by Michelle Sholzberg and another one that came later on with even more studies in the meta-analysis. So we felt that it was important to include that it's also to reduce death. Because the problem is, and even in our hospital, we don't see this regularly being performed, therapeutic heparin given to these non-critically ill hospitalized patients. And it's like the internists don't believe in it. But if we say to reduce death, maybe some more of those will believe in it.
So that's really the big change.
I think that is the most important change, although it didn't change the class of recommendation, which was already the highest and the evidence level, but the word death was incorporated there to prevent death. So I think semantically that is the most important. Now, was there a change in recommendations? There was. We were more convinced that intermediate dose low molecular weight heparin is not, there's no benefit from that. So there were more studies coming out, and altogether we felt that that could increase the quality of evidence to that don't go for intermediate, don't try to mess with it and go halfway. You go full way with the therapeutic dose. And there was also another recommendation. So we had before about DOAC, that it's not helpful, but then there was also that there is a possibility that apixaban actually is good, because there was a study, the FREEDOM study, that compared low molecular weight heparin at therapeutic dose with apixaban versus prophylactic dose. And both apixaban and low molecular weight heparin at therapeutic dose were equally good. Now, so this is only one study with apixaban, so that's why we were still a bit hesitant about it. So we say 2B might be considered. We still think that one should prefer the low molecular weight heparin, but it was a large study, the FREEDOM study, and we felt that it needed to be there somehow.
I just wanted to add, if that's okay, that we acknowledged on the guideline panel that there remains a large knowledge to action gap. And with the rapidly accumulating evidence and the additional evidence that Sam had just reviewed in patients who are non-critically ill but hospitalized, the addition of that outcome death is really important. And obviously that is based on the evidence that was available to us. But we thought that it was really important to emphasize that in particular for the readers of these guidelines, because of course we can't speak specifically to vaccinated populations, nor can we speak specifically to current variants of COVID-19.
Right.
But we all agreed around the table that if in 2024, you have a patient with COVID-19 who's sick enough to require hospitalization, that really none of us would have hesitated to provide that patient with therapeutic heparin, in preference low molecular weight heparin. And so the addition of the word death as an outcome is based on the evidence. And also, I think the discussion around the table is that this was really what could be a more important outcome to emphasize. I just wanted to highlight that because Sam was saying, for the internist that's reading this and who's caring for patients on the ward who are not critically ill, but sick enough to require hospitalization, that we really thought it was important to emphasize what the literature is telling us.
Right. So now we can move to the critically ill hospitalized patient. How was the recommendation here, and was there a difference from the previous ones?
So there was no new recommendation. There was a little bit of modification because there were new studies and that prompted us to upgrade quality of evidence in several cases, in actually all the three recommendations, from level B randomized studies to level A. So there were more randomized studies, for instance, telling us that intermediate or therapeutic dose heparin or low molecular weight heparin is not beneficial. It's not adding anything. It could be harmful even potentially with more bleeding, but it's enough to give these patients the prophylactic dose unless there is another indication for therapeutic dose. So if they have atrial fibrillation, or if they have mechanical valve, or if they've already developed a deep vein thrombosis or pulmonary embolism during their hospitalization, then of course we have to give them therapeutic dose. But otherwise, we should not. We should stay with the prophylactic dose. And also with regarding to the antiplatelet agents, so there was a wishy-washy recommendation in the 2022 guideline that it's not well established, but it might be considered to give a low dose of aspirin. And that was based on the REMAP-CAP study that showed a likelihood of reduced death, but then there was a recovery study that didn't show it. And then there were new studies added now that showed that it was not beneficial. It was harmful, more bleeding to add aspirin or clopidogrel or whatever they did. So that's why we don't think there is any benefit, and we upgraded the level of evidence now to A there.
Right. So I want to take a minute here to talk a little bit about the definitions. I read in the paper that you exercised a lot of caution while gathering the evidence about definition. Was there issues in the definition in those selected studies about the critically ill and non-critically ill that you want to highlight?
So critically ill is slightly differently defined in these studies, and it was impossible to tease out the patients that were exactly the same from all these studies. So we were forced to use the definition given by the authors of each study, that whatever they called critically ill, if they just used that. If they said treated in the intensive care unit or in an intensive care unit setting, we would consider that, of course, critically ill. But if they just said critically ill, we had to take it as it was. So yes, there can be slight differences between, and we know also that depending on the resources in different countries and different hospitals, some critically ill patients may be treated on a regular ward because there are no beds anymore in the intensive care unit or similar level of care, and that's what they have. So it is a little bit problematic, and we acknowledge that.
Right. So what about the patients following discharge from hospitals? What was the recommendation of the anticoagulation there?
So we had one study previously, one recommendation, and that was a weak recommendation about rivaroxaban, that it could be used for patients that were at higher risk for 30 days after antiprophylactic dose. Then there was a new study, a large study with apixaban, but it had several methodological problems, and it was criticized in editorial and in other ways also. It really didn't come to any conclusion about apixaban, but it didn't show any benefit, although maybe that was due to the methodology of the study. But then there was a clear trend from a large number of studies that the severity after discharge was becoming lower and lower, so that people were doing, even after, if they had been hospitalized, they were discharged, they were doing better and better, and the mortality was lower. So the vast majority of patients do not need any anticoagulant after discharge. That's the clear recommendation. It's based mainly on this clear trend we see that it's not needed. They are doing well after discharge. And then this study with apixaban supports it in a way. So we have this new recommendation that for the vast majority, routine prophylaxis should not be given post-discharge. And then for the rivaroxaban, we say even more clearly that it's select high risk. So not only high risk, but select. So it's a very small population that has high D-dimers and other risk factors that predict that they will have thrombosis.
Right. Well, thank you for this. So now I'm curious actually to ask, were any of the recommendations tailored to patients' vaccination status or relevant even to the severity of illness? I know I read in the paper that you thought about this, or even the variants of SARS-CoV-2, because we had several variants across the pandemic era. And if not, why not?
So we were really hoping that with this second phase, this update and new randomized studies coming out, that they would give us that information about specifically the new variants. And we were disappointed because most of those studies had been going on for 2 years. So they included both all the periods and all the variants, or they didn't specify the results per sub-patient group. So we were not able to tell that, unfortunately, the variant-dependent recommendations. And also the same with vaccination, that it was not clear how the results of the studies differed between those subgroups. One can only assume that in the later phase where a lot of patients were vaccinated, that there was only a small proportion of those that were hospitalized and that were critically ill that had been vaccinated, and that the vast majority of those were not vaccinated, especially those critically ill. But we don't have the exact data there.
Yeah, that's fair. Well, I think it's now time to move to the COVID-19 vaccination with and the VITT section, which is a new section on this updated recommendation. So tell us what are the recommendations there?
Sure, I'm happy to. So this section was led by Donnie Arnold and included a group of individuals, including myself and Jeannie Connors, Anna Falanga, and Isaac Nazi. And the recommendations here, just I should emphasize that, of course, we didn't have randomized trials for VIT, nor large studies. These were all observational. We set clear criteria about the types of studies that we would include. For example, we set a limit that at least 30 patient participants had to be included. But just to emphasize that we were dealing with a very different evidence base here. VIT is a rare disease, and we had to acknowledge that and sort of adjust the approach. And also, as Sam described earlier, that the rubric that we used to evaluate the level of evidence, et cetera, wasn't exactly applicable here. So we had to adopt a different rubric that considered diagnostic tests, et cetera, and their performance characteristics. So with all of that said, we thought that it was still really important to make some recommendations, acknowledging that there are some parts of the world that continue to use vaccines, adenoviral vaccines, that may carry an increased risk of inducing VIT, unlike, high-income countries where those vaccines are no longer used. Right. So just to emphasize, we thought it was really important to include this section because we all thought that it remained an issue of health equity globally, and we wanted to make sure that we could provide some guidance for our colleagues internationally. So we made a few recommendations. Number one, for patients who have a history of thrombophilia, that there was no need to provide anticoagulants or antiplatelet agents to reduce the risk of adverse outcomes when patients are receiving vaccinations. The strongest recommendation that we made is that for diagnosing patients with suspected FIT, the use of an antiplatelet factor 4 enzyme immunoassay is recommended, in contrast to our recommendation essentially against the use of rapid HIT assays. And so that's a really important distinction because many labs use rapid HIT assays, and we're using it initially before we understood what FIT was, and acknowledging that there seemed to be a similarity with HIT, that these rapid HIT assays are not sensitive nor specific in picking up VIT antibodies, which are different. And then additionally, we suggested that for patients with VIT, that a non-heparin anticoagulant was generally, we thought, would be the first agent that one would use. But if it was not available, that a heparin-based anticoagulant is appropriate to decrease the risk of adverse outcomes. And then similarly, treatment with IVIG may be considered to reduce the risk of death. So those are the recommendations in a nutshell.
Right. So thank you for this. And if I recall correctly in the paper, so the period of search even extended beyond the original one to FIT and to allow all evidence to be gathered for the FIT. Is that correct?
Exactly. So that was, after a lot of discussion with Sam and the entire panel, we acknowledged that the evidence was rapidly evolving. And so we thought that it was only appropriate to extend the search to, essentially the present day or close to the present day.
Right. And I want to take this opportunity to guide people to look at two important figures in that paper. You actually nicely and elegantly summarized the guidelines and level of evidence and class of recommendation in those two figures. So those would be useful for our audience. So I guess, was there anything else that you would like to discuss that we didn't ask throughout our discussion today?
No, the interesting thing is that we had this out for public review, and sometimes guidelines get hundreds of comments, and we got less than 10 comments or critical comments on these guidelines. So either, I don't know if we should take it people were not interested or that they were happy with this updated version. I hope that it's the latter. And it has been published also, as you said, in JTH, and there has not been any commentary, any letter to the editor complaining about anything there. So I think I take that as a good acceptance from our community. Now, of course, this is in Journal of Thrombosis and Hemostasis, and we have to go to Journal of Thrombosis Hemostasis in principle first, because this is a guideline sponsored by ISTH, and they want it in their journal. So the risk is that it's not read by internists, as we discussed before. So it is upon the panel members when we are invited to speak or when we get a chance to be invited that we talk about this and talk about the highlights of the recommendations or the modified recommendations, so that we spread it to other specialties.
Right. So thank you for this addition. Michelle, do you want to add something?
Sorry, I did. Thank you. I just wanted to emphasize the speed with which these guidelines were produced, the first iteration and then the second iteration. I've previously been involved in guideline initiatives, and I have to say, I have never seen a chairperson like Sam Schulman move as quickly and swiftly and expertly, nor have I seen a methodologist, Helene Resnick, move so quickly. And all of the panel members, everyone was incredibly motivated to move very fast. And, we fundamentally would not have been able to do this without Sam's leadership. And I wanted really to emphasize to the learners that it really takes a dedicated leader to be able to push something of this quality through with such speed. And I think it's important for people to know that all of the panelists emphasized repeatedly on all of our email threads how grateful we were to Sam. So I just wanted to say that publicly.
Thank you, Michelle. And it was necessary because this is a fast-moving topic, and we don't want a guideline to come out that is already outdated. And this was also a mandate from ISTH with the first one. We want it done within 6 months. They didn't really believe that we would do it, but we did it, thanks to everyone.
Well, wonderful. And I want to thank you both for this wonderful discussion. And I certainly learned a lot. And I'm sure our audience have felt the need to listen to this and summary of the recommendations. Maybe one last quick question. Do we think this recommendation apply to all countries? And do you think the geographic distribution and the resource setting difference would still benefit from those recommendations?
Yeah, I think it does apply to all countries. We were thinking, and I have, during the work, I asked colleagues from Africa and South America if they are relevant, if the drugs are there, and they said, yes, definitely this works for us.
Excellent. Well, this is important because ISTH and JTH's readership is across the globe, and we want to make sure that this applies to everyone. Well, thank you again so much for this discussion, and it was a pleasure meeting you both today and discussing recommendation.
Well, thank you all for your participation this morning. Thank you, Maha, for leading the discussion solo for the first time this season. And really appreciate both Sam and Michelle participating today. And I want to thank our listeners for tuning in to CLOT Conversations from Thrombosis Canada. We welcome your comments, questions, and suggestions on the podcast. We really do. If you have any recommendations for future podcasts, please send them to us at info@thrombosiscanada.ca. And please subscribe to this podcast so that you are notified about the release of new episodes. And don't forget to check out our website for educational programs, clinical tools, and guides. And also, please consider donating to Thrombosis Canada to support our ongoing efforts to reduce morbidity and mortality due to thrombosis. Thanks again, and that's it for today.
Thank you.
Thank you. Bye.
Thanks,
Have
everybody.
a great day.
Thanks, you too. Bye-bye.
Bye-bye.
Bye.